Yes, I think you're audible.
Okay, fine. So now this presentation is on ethics in ECMO, and we have esteemed panelists. So I'll share few cases with the basics of ethics. Now, obviously, no disclosures and conflict of interest. And my goals are for the patient's best interest, its autonomy, its informed consent, shared decision making, surrogate decision making, and end of life care. So these are the goals which we are going to discuss in every cases uh, today. Now, whenever we talk about ethics, we should discuss about the principle of ethics. What are those? These are the four things. And for each case to describe, we need to follow these four ethics, principle of ethics rules. Like first one is the beneficence, that whatever you do, good of the patient comes first. Second is the non-maleficence, do not do any harm to the patient. Third is autonomy, patients have right to choose or refuse the treatment. Fourth is the justice. Justice means the scarce resources should be distributed fairly. So these are the four things, principle of ethics, we are going to discuss today. And current burning issues, sometimes we face regular basis, like patient is DNR, but ECMO is acceptable. CPR acceptable, but not ECMO. Do not intubate, but ECOR is acceptable. Do not ECMO orders. And what does actually the do not resuscitate ECMO, do not resuscitate means on ventilatory ECMO? And moral distress. Now, coming with that thing, coming with the case number one, which is a 48-year-old male post-renal transplant with COVID ARDS on ventilator. Now, his PCO2 is more than 140. The ABG could not read what is the actual PCO2. They are showing PCO2 is more than 140, pH is 6.8, PO2 is 44. He is on triple vasopressors. A retrieval call came for him, which is almost 100-kilometer distance. One episode of bradycardia, which responded with adrenaline purge. On arrival, our ECMO team found pupils bilaterally dilated and not reacting. So, I'll ask Ravi, Dr. Ravi, how we are going to manage this case.
Sir, with the pupils being dilated, not reacting, and with the presence of significant hypoxia, I would also like to see whether other brainstem signs of death are also present. If they are present, I would rather prognosticate there will be no, it's rather a futile attempt even to go with ECMO or an ECOR for this case.
Okay. Vivek sir, are you happy with the way he's, because after 100-kilometer distance, we have gone with the team and found this, and relatives are waiting that some miracle is going to happen. So what are you going to do?
Okay. So what I will, after approaching, because when we talk about only pupils dilated, it is hypoxia. We can see that the PO2 is just 44 and PSO2 is too high. So both these conditions can lead to a pupillary dilatation. So it cannot be a good surrogate for assessing the patient's neurological status. And when we look at this, this situation of hypoxia and hypercapnia, possibly having a bradycardia is quite common, and patient has responded to the just a purge of adrenaline. He still did not have any cardiac arrest or did not require CPR. So I will discuss with the family. And in this situation, you cannot do a CT, you cannot do anything, and your patient is already paralyzed, because with this PO2 and PCO2, you are not going to keep your patient awake to assess the neurological status or looking at the reflex. So I will discuss with the family. I will tell them the truth. Not that just because I have come from 100 kilometers, so I'll say I want to put ECMO. You have to have a very balanced discussion with the patient's attendant that this is the scenario, this is what exactly happened in front of you, that he required some drug to improve the heart rate. But this was not a cardiac arrest, and because there is no cardiac arrest, we do not expect any major issues, but there are possibilities. And moreover, the first response from any relative you will be listening that do a CT scan. So explain them that it is not possible in this condition to shift this patient to a CT scan room. So we have to take chance. We have to, because ECMO is a treatment of uncertainty. When we as an ECMO physician, when we enter, at that time, the situation are very, very dynamic. So we have to discuss it in the balanced way. We have to explain every pros and cons, and we should put these patients on ECMO, and you should have a clear consent from the patient relative, clear communication before taking consent, clear counseling of the relative that there is a possibility that the exercise can be futile and we can reach to a situation of ECMO nowhere. So all these once you explain, then definitely put these patient on ECMO. Only word of caution, PCO2 is above 140. So be very careful when you are placing these patients on ECMO. Reduce carbon dioxide very slowly. Otherwise, there is a more risk of intracranial hemorrhage in these conditions.
So here the ethical issues, as Vivek had told and Ravi was also pointing out, that there is an uncertainty. What is going to happen? Now, if uncertainty comes into play, you have to think about three things like probability of benefit of treatment, ambiguity. The ambiguity that somebody is checking whether the pupil is dilated, I'm not going to put ECMO, and somebody is telling I will put the patient on ECMO. So there is an ambiguity and complexity of the case where survival is in question. Now, with that, we are open to moral blame, but patients should not die of a new technology available things. So probably ECMO is justified, and after taking proper informed consent from the relatives that this might help, and this probably a transient event because of higher PCO2, this people is bilaterally dilated, and probably we can give a last chance to him to get back his life if even the 10 to 15% chance is there. So with that thing, coming to the second case, a 11-month-old septic myocarditis with pneumonia, already 21 days of ECMO. Suddenly his CFTR gene came positive. So somebody told this the case is cystic fibrosis, and now after 21 days, I need to change the oxygenator because lung is not improving. The heart has improved, but lung is not improving. But after getting the CFTR report, parents does not want to continue further because they have been told that the cystic fibrosis has not much of hope. So Kapil, how we are going to face this issue? The baby is playing on ECMO, alert, awake, and the oxygenator is going down.
Okay, so I think it is in 21 days of ECMO run, and now it is the right time to change the oxygenator. And if the treating team is willing to do, and the pediatricians and the treating team nowadays, if this question was asked me a decade prior, I would say we can withdraw the support as there was not much of treatment regarding the cystic fibrosis diseases. But nowadays, if we go through the current literatures, the literature says there are fair chances of a treatment as far as the particular disease is concerned. So we should start counseling the family regarding the cystic fibrosis, what would be the probable possible outcome regarding this, options available currently for this disease, and if I think after proper written consents, if family willing, I'll go and to change the oxygenator, and we'll continue with the ECMO supports.
So it's a wait and see strategy. Probably a good communication with interpersonal conflict, complicated grief with the family. All these are going to play. So we are here just to have a better communication of the prognostic uncertainty. Obviously, the beneficence of the patient comes first, and do not harm will come obviously the second one. But we have to discuss this case with the relatives, and what happened actually, ultimately they didn't give consent, and we could not change it because of non-consent, and the baby died. So probably some autonomy with them, with the baby. The parents can take the consent. But without their consent, you cannot do anything on this kind of situations. But lot of moral distress happened because the baby was playing on ECMO, and we are letting him or her go without changing the oxygenator. So that's a bad thing, So that leads a lot of moral distress to the nurses, and we had one nurse went into very much grief situation, and we had to counsel her for at least 3 months to get her back to the normal work. So these things will happen, and it's a case of moral distress thing. We should look into it. Now,
Sir, can I add?
case number 3.
Hello. Sorry to interrupt.
Please.
Yes. So the disease name was cystic fibrosis, and family come to know. So by and large, if it is a non-medical family, there has to be some guiding persons in the family, as far as the referring physicians or whosoever is there in the family or the distance family. We should take them also in the accounts, because first important point here is we should take a decisions after counseling of the treating teams as well as the referring teams. If we take in a confidence of all the parties are involved, then I think it is easy to get a consent from the family, because being an ECMO physicians, if we consider we only want to do this, and if we will get a consent from the family, it is not such a case in day-to-day practice. So we have to take all the parties involved in the accounts, do a proper counseling, and then I think if we had convinced and come to a family, they might be agree with us.
Yes, we have sit with the family probably 4 to 5 times, and they were not sure about the outcome, because they don't want to go to, if the lung transplant is required at that 11-month-old, like an year-old child, and probably the outcome was not very good, as you all know at that point of time. So it was discussed, and the good part of the story is I got a WhatsApp message after 1.5 years of this event that sir, a new guest has appeared in our home, so the second baby has appeared. So probably this is the best part of the story you can share from this case. So case number 3. Now this is a COVID situation scenario. 50-year-old male, severe COVID ARDS with PF ratio of 0.5, after 2 episodes of proning and 3 weeks of HFNC, got shifted to our hospital. Now only one ECMO CentriMag backup console is free. Other 21 machines are running. This is a pandemic situation. Now, at the same time, in the emergency, a 22-year-old amlodipine poisoning came after 18 hours of ingestion in shock. So, Ravi, whom you are going to choose, or anything you are going to do? 21 ECMO running, only one backup console is free. You have 2 patients, COVID ARDS, 3 weeks of HFNO and 2 episodes of proning, failed, and a new patient, 22-year-old amlodipine poisoning in ER.
I think here one of the ethical principles which you have just mentioned comes into place, sir. Justice. How do I divide this resource which both people need? Probably I will try to manage the amlodipine poisoning as much as possible conservatively, if at all his requirements increase to very high or he's at an imminent cardiac arrest, only then I'll probably connect ECMO to him, sir. And the same goes for even for the ARDS case. I'll try to manage both of them as much as possible without an ECMO.
So, but you have to keep in mind that your other 21 patients are on ECMO and only one backup console is free for you. It's a backup console.
Yes, sir. That is the main concern. If I put ECMO for any of them, if any of the 21 machines fail, any of them can be in jeopardy.
So, you are choosing not to put on ECMO both of them and just wait.
Yes, sir.
Okay. Vivek sir?
I'll bit differ on this because I'll look at this situation in a larger perspective. The first, as he rightly mentioned, that we are left with one console only, and that's a backup console. So if you use this console, that means you may land up in a problem with any equipment failure and you will have a collapse of the patient. But similar situation can happen to the second time also. So at least when I'm using so much of it, means it's ECMO center, it's a cardiac center. So we have a centrifugal pump with us. So we can, keeping in this mind a resource limited situation when there's a pandemic situation, we can always use those centrifugal as our roller pumps as for backup console. That's one. The second part of the question is, there are two patients coming simultaneously because we always work on the principle first come and first serve kind situation. But here the first patient is on HFN only. Still he has not been intubated, not requiring even non-invasive ventilation, and so we have a time for this patient. However, we know if the amlodipine toxicity patient, they might not require ECMO for a very long time, and he is in cardiogenic shock. So possibly, I'll preferably keeping a backup with the roller pumps, will use ECMO for this amlodipine toxicity in this particular situation, and because I still have a time for that patient may need an IV or may not need even, in fact, may be managed on HFNO itself. So probably I'll try to manage the amlodipine toxicity first as and will wait for the other patient and will keep a backup console with the roller pump.
Sir, I want to add one thing.
So, yeah, please.
Sir, this machine is also the backup console for 21 other patients. So if any of them suffers a pump failure and we have to change, there is no other console. And assuming the roller pump was a backup for those 21 cases, then what would be the case?
So, probably justice is universe. This thing. What we have seen during COVID, that with the increasing patient volume, there are surge of patients. In a latter part of the surge, you are getting a lot of ECMO patients, and how we are going to do these things. And obviously, with the increasing number of things, sometimes the quality is also decreased. So, with that thing, what we have done, we put the amlodipine poisoning patient on ECMO. And obviously keeping those roller pumps on backup. We have asked for another 6 machines because it was in the running phase of the second wave, and we needed more and more patients were coming, and we continued this first patient, that is severe ARDS, on this patient on proning and all these things. But ironically, this amlodipine patient, poisoning patient, we could not save her because came very late and already MODS has happened even on ECMO. But this guy without ECMO, he survived, and he got out of this danger situation. So sometimes probably God has different plan, but you have to abide all these things. A lot of centers at that point of time have stopped doing veno-arterial ECMOs for AMIs, for other things, because it was kept for the pandemic situations. So you have to keep in mind, in pandemic situations, sometimes the ECPR was not promoted at that point of time in MI, even in MI patients, because the ECMOs were kept for the COVID patients particularly. Now, Coming to the case number 4, probably this is a very common case we all face in our regular day-to-day practice. He's a 62-year-old, extensive COVID fibrosis in CT on VV ECMO for 140 days. Family counsel for lung transplant since 2 months, but they denied repeatedly. He is awake, alert, and communicating. Repeated attempts failed for weaning because of extensive fibrosis. Now, on day 140, he landed in septic shock. Now, family wants to escalate to VA support or whatever more can be done at that point of time. So, Kapil, what is your take in this? How we are going to manage?
Very tricky situation, sir. Already 140 days old, so it is too long for a ECMO, and definitely the treating team has taken a good decisions. If patient's multiple attempt has been failed to wean him from the ECMO supports, so it is a too long ECMO, and I think an ECMO dependency we should think on it. So definitely the lung transplant is the only options, but if a third or fourth line you have mentioned that septic shock, so lung transplant is also out of options. So we should, as of now, if the septic shock is there, we should not talk about the lung transplant also. So both the situations is very, very difficult. Now coming to a family part, family wants to escalate the supports and to convert to a hybrid mode of ECMO from VV to VA. But we should think of the other sides also, because even the VA ECMO, I don't think so he is going to survive out of all these sorts, because VA ECMO will not recover the lungs same times also. So there are other adjuncts to the therapy other than the antibiotics. We can add the CRRT machines, we can increase the extracorporeal therapy like cytosorbs and alls. So we should some upon a time we should not give all the options to the family, and we should avoid the VA ECMO as far as my knowledge is concerned, and we can do with the CRRT or the cytokine release therapy, we can escalate the antibiotics, but I am not in favor of a lung transplant or a VA ECMO in this case.
Vivek sir, how we are going to manage these ECMO to nowhere situations?
Great. So, in addition to what Kapil said, the first thing, actually a role of ECMO physician begins much earlier than this, because this is the expected course. Once there is a 140 days run, that means we are expecting that at any point patient is going to have a sepsis hit and will have multi-organ failure and deterioration. So usually once the 8 to 10 weeks are over and we are finding a non-recovery, and as you said rightly that repeated attempts of lung transplant were suggested and that was refused with the family. So here comes the role of patient's autonomy, that if the patient was awake, conscious, so I think this would have been the right approach in these situations, that you start talking to the patient and take patient's opinion, not only the family opinion, because definitely to thinking that my near and dear is sitting awake and we are leaving, we are thinking of a withdrawing ECMO can be a very distressful situation for the family, and that is why they are most of the time on the denial mode. So first and foremost thing, we should talk to them as early as possible that this is the situation and we are reaching to a ECMO to nowhere situation. That is one. Second, I fully agree what Kapil said, that putting this patient on VA ECMO is not an option, because we have already 140 days have exhausted and he is in septic shock, septic myocarditis, using other modalities, so that family when feels that this is being done, something is being done to save him, and if he improves with these therapy, there are possibility that you can extend. The third is in this kind of a conflict situation, the legal immunity, because in our country still this is a situation where you have to take a lot of opinions, lot of discussions, so many things. So I think at this stage, a second opinion, use of making a board in the hospital who is discussing with the family, involving legal department of the hospital. And if this conflicts escalate, because sometimes patient relative comes getting an opinion from some other doctor, no, no, you support with a VA code, this will maintain the hemodynamic, because theoretically it does. So in those situations, probably approaching to the court to get the directives will be helpful for the clinicians, because nowadays um, anything can be projected, and as a clinician you may land up in trouble with the best interest of the patient you are doing, but still you may land up in the trouble. So all these things should be taken in consideration. But yes, ECMO should not be indicated in this situation. We should use other modalities, escalating antibiotic, using a steroid, using the other extracorporeal therapies, so that we can filter some of the cytokines with the intent that possibly hemodynamics will improve.
So with that thing, what are our challenges? That patient being aware of fact of impending death can be distressing and suffering. Family withdrawal decisions are emotionally challenging for them, because a patient is eating, patient is talking, patient is reading newspaper on ECMO. And for the healthcare providers, when this kind of patients dies, moral distress and close ties with the family, 140 days, the family is very much known to them, the nurses, the technicians, the doctors. So there is a lot of moral distress. This kind of patients living after 140 days, and nothing can be done. So very difficult. At that point of time, we have not escalated to VA, but obviously we have tried with cytosol to get this thing, but ultimately he died on day 146 and we could not do anything. So ECMO to nowhere is a very important part of our practice, and it is not easy to deal situation, but the way Dr. Vivek sir say that we have to prepare whenever we are putting the patient on ECMO, we should think of that there should be an exit. And this is the way where we have to think for each and every patient when we are putting in. Now, coming to a case of 29-year-old post-LSCS COVID ARDS, non-responder of proning, shifted to our hospital, rescued on VV ECMO, lungs are white even after 21 days. Now, family belongs to a village where flood take away all houses, and they have nothing to continue the treatment at that point of time. Now, my question to Venkat sir, what to do, sir?
Sir, whenever a hospital starts a ECMO program, the management has to keep a pocket of margin of to bear the losses. So they have to have some funding system where you will be stuck, and there has to be an helping hand from the management, either by giving concessions or waiving of the charges, or giving medicines at cost price, or in such cases where there is no money coming, then maybe something from the management to help the patient should be there. Otherwise, these situations will come. They do come frequently. The family is burnt out of finances. Even middle class family, after 10 days of ECMO, are all left with no money. So this situation comes. So here the management role is very important, and of course the consultant can waive of the charges. Patient cannot be left at this stage because there is a possibility of recovery, but then endlessly no one can continue. So for that matter, they can go for crowdfunding. There can be some voluntary donors and other things, of which the medical social worker may be having some list who would help the patient. So the entire hospital and the management has to give a helping hand to continue the ECMO.
Being a part of the corporate hospital, how you are going to manage this case?
Maybe a meeting with the management committee, keeping the uh, benefits of saving the patient and getting recognition for the hospital may be a driving force for the management to consider financial considerations, one, and then social media for crowdfunding, two, then using your own resources from the consultant of few donors who have survived ECMO, or maybe other people who are willing to donate for such patients. Such thing can be initiated, and waiving of the charges. That is what you can do at your level.
So probably a basic minimizing the charges, reducing the cost, reducing the investigations, and probably looking at the longevity of your oxygenator, and by doing extending the basic care, you can reduce the cost, and ask for the management to step up for this patient, because she is only 29-year-old post LSCS, a new mother, and there is a fair chance of coming out. So this is probably the part we face always, and I'll share what happened to this patient after some times. Now, coming to the sixth case, after coming,
sir, 1 minute, one minute. Dr. Prashant would like to add something to this case.
please, Prashant.
Sir, this is if we don't continue ECMO, maternal mortality will be there. So nowadays, government also helps to reduce the maternal mortality. And as Dr. Venkat sir said, we can approach the government authorities through the corporate hospitals, and rest all the things have been already told. So that we can do.
Yes, this is the thing where we should also involve the government funding, if any a PM Care Fund or some local state level fund, so you can ask for it, obviously. So multiple areas of funding you can mobilize, and probably reducing cost is another thing which is most important, because funding is a one part, but another thing is you have to reduce the cost, the daily cost, and you have to keep the bill a little bit down, so that ultimately it doesn't go up. Now, coming to the sixth case, after coming from ESY workshop, I got a case of 6-year-old child with severe ARDS very next day. As I have never cannulated any child, I have asked cardiac surgeon to cannulate, but he told his pediatric exposure is not optimal. He can try. You called Dr. Vivek Gupta, as he is available in Mumbai, and he can spare his time and reach to your place within 4 hours. So he is a mentor now. Now, cardiac surgeon is very much in hurry to put the ECMO early. How we are going to plan this kind of things? One should plan this kind of things after getting the ESY this workshop certificate. Vivek sir, I will ask extend this question to the participants. First, Vivek sir, if you can put some light.
Okay. So attending a workshop, even getting some training related with the various complications or cannulation may not be sufficient to perform ECMO. This is probably the most important thing all of us should keep in mind. And second most important thing, never hesitate in taking help, because imagine you are doing a procedure in a situation when a patient is crashing, because ECMO is never initiated in an stable patient. So patient is crashing. And if we add on complication, because we have just got training, but we don't have much of experience, and doing a small child, it can be disastrous. So the role of mentors and mentees is very, very important. And in fact, ESOI has taken initiative for this, that we are always available to support, we are always available to guide if anybody is doing ECMO and having problem, leaving aside the child. Even for an adult patient, we always discuss amongst ourselves and with anybody who requires help. So this is, I think personally, if you ask me, if I'm not confident about a particular procedure, and that remains true for any intensive care procedure, and ECMO when it is extreme of intensive care, so I will not take a chance just for sake of doing it, but I will try to put a person who can be a best in this situation. So I will see that whosoever is the most experienced person is placing, but yes, I'm also learning in those situations so that I become more confident when I look at the real scenarios and I understand the challenges and I get the tips and tricks from that person that will be helpful. So I will wait in this situation for a person who is most experienced are having a good knowledge of the subject.
So, Dr. Prashant, any thought on this?
Yes, sir. Here the principle of non-maleficence comes into picture. Do not harm the baby. So expert is arriving in 4 hours. So till then we have to manage, and I will also try to convince the cardiac surgeon that give me some time. We have to be little smart that I am preparing the patient and family, and till then the expert will come. So till then we will not harm the patient because I am unexperienced or the cardiac surgeon is not experienced. So we will buy the time and will manage the patient till the expert arrives, and 4 hours is manageable time, I guess.
So it's a clear-cut message to whoever attended this workshop that you should follow these things, and we are all available for your call if you face this kind of situations where the ECMO is not very straightforward and it needs some help from us or some mentorship. May not be physical, sometimes over the phone, sometimes over the video call. These things are it's available, and all of us are ready to share our experiences which are good and bad for last 15 years, and probably this is going to help immensely in your building your ECMO practice. And it needs a 3-day workshop is fine, but probably you need to do lot more before going to a regular case in your center if it is not already established. So this is a clear-cut message from us. Now, coming to the last case scenario, suddenly one fine morning, a bystander rescued a young adult from the pond adjacent to your hospital, alleged drowning and found pulseless with no respiration. So they have started CPR and brought the patient to the emergency within 10 minutes. But not sure that how long he was under the water. No family members around. The guy is having recurrent cardiac arrest with unstable hemodynamics whenever ROSC is happening. ECMO code is activated. So Kapil, what are you going to do?
Definitely being an ECMO physician, and already like in code blue nowadays ECMO code is also activated in the hospitals. I think I should start doing an eCPR in this case. Why? Point number 1, it is a young male. Definitely time limit we don't know, but when the CPR was started to coming to a emergency department, exact time limit we have, it is in 10 minutes time. So young male within a time. Of course, no family members are around, but being an medical personnel, it is my duty. Like sometimes we see a case, or nurse whosoever is working with us is fainting in front of us. We are not waiting his or her family to come and give a consent. We should start a primary treatment to this case. So looking at this scenario also, if family is not around, I'll start cannulating a patient. In same time, I'll ask a hospital management also to be in accounts. Same times I'll do a MLC, which is a very, very important point. We should do a MLC because it is an unwitnessed and we don't know how he has went into a pond, so we are not aware. So MLC is must. Hospital authority management should be informed. Police should be involved. But at the same time, my role is to start an ECPR and start doing an cannulation in this case.
So my question is, who is going to sign in the consent, or is it consent is not needed? And what is your take on this?
Very good questions, but very tricky. Without consents, I can understand. But at the same times, if we intubate these patients, same scenario should come over the period of time. If we want to do an ECPR program in our institute, such cases will come to you a day and out. Okay. So I think I will not wait in this case for the consent. I'll start. Definitely the hospital should ready to bear some amount of money, but at the same times, without consents, I'll start doing an cannulation, at least in this case.
So I think you are right that a drowning case with a no flow with a low flow time of 10 minutes, no flow time obviously we don't know, and a young adult, probably a good case of ECPR when it coming to an emergency. But you know, if what will happen if the family comes after that and they are telling that I have no money, the family is very poor and I cannot run the treatment. You have put the patient on ECMO, little bit stabilized. You are not sure the patient will get awake or not. So Ravi, any light on this?
What is the possibility that we do a CPR for another 20 minutes and see before putting on ECPR?
Sir, if I may add, we do not know the duration of the arrest. The duration of no flow or low flow time, we do not know. And second, the
low flow is 10 minutes.
No flow is not known, sir.
No flow is not known.
So it was an unwitnessed arrest. And second thing, the law of the land, our country dictates that the best possible care.
But you know, I'm telling you, no flow time in drowning, it will never be calculated. It will never be possible to calculate it. Drowning, hypothermia, electrocution, these are the cases where no flow time is, you cannot calculate. Vivek sir, anything?
Yes, because what I'm seeing, the patient is having we are achieving ROSC. If there would not have been any ROSC and whatever we are getting as a straight line asystole since beginning and not a single time ROSC has been achieved, definitely I will not put ECMO in this case. That's one. Second, because I'm achieving ROSC, but he's having a recurrent cardiac arrest, so definitely he becomes a candidate for putting up for a ECMO CPR. The second issue is the consent, what we discussed. So in this situation, probably a responsibility of a single physician can be challenging. But yes, in emergency, when you are being called as an ECMO physician, there must be some primary physician who is there for this. Along with the administration of the hospital, a joint consent can be signed by the primary physician as well as the hospital administration that yes, we can go ahead with the best interest of the patient since patient's relatives are not available, and whenever they are available, the consenting process can be continued in those situations. That's second. And third most important thing, in these kind of a situation, when the conflict starts with the relative, most of the time in Indian scenario, because we are paying, the family pays from its pocket. So putting an endotracheal tube, 200 rupees, 300 rupees. But putting an ECMO will be a charge of 2 lakh rupees. So definitely, hospital should have a generous approach in this situation that if the patient is not being revived, then possibly they have to look for a means to waiving off fees if family is not paying, because that's one of the biggest reason of conflict in this situation. So I will be going for ECMO because there is a ROS and patient is having a stable hemodynamics. Consent, I'll make sure that at least 2 people are signing, not the person who is going to perform ECMO. Other 2 people are going to sign on the file that yes, we feel that this is the best interest of the patient. Rest all formalities can be done that.
So whenever you have you have your ECMO code in your hospital. So these kind of cases are going to come. As Dr. Vivek sir said, there are few points which are absolutely matching with your ECMO candidacy. Number one is a young adult. There is a drowning. There is a clear-cut CPR started whenever he found, and there is a shockable rhythm because the patient is having intermittent ROSC and unstable hemodynamics. So this is a clear-cut recipe for an ECPR, and probably with the consent of two people at least around, we can put the cannulas in. And to reduce the cost, you can use a temporary oxygenator of your CPV for 24 hours and see how it helps. So this, we can reduce the cost from 2 lakhs to CPV oxygenator comes around 25,000, which is primed circuit should be there in your emergency to combat this kind of cases. And we did the same. And but unfortunately, when the family came, it is turned to be there is a doctor in the family, and he actually praised our thing. We put the patient, the patient responded on ECMO, but ECMO came out. But unfortunately, the low flow, the no flow situation was not known. He didn't wake up, and we lost him on day 49. Even after everything got settled, we took out ECMO and everything settled, but his brain didn't wake up. There is a massive hypoxic brain injury happened. So these things happen, and with that thing, I'm concluding today's ethical thing. And ECMO helped our fraternity. This is the doctors who got saved. So keep giving ECMOs. And this is the lady with day 81 of VV ECMO. We have supported till whose house got blown away by with the flood, and we continued her for 81 days with a single oxygenator, and a lot of help from this, and hospital helped us like anything. The bill was around 70 lakhs. They could only pay around 25 lakhs. The crowdfunding added around another 20 lakhs, so rest of the things are managed by the hospital. So thanks to the hospital who has done this. And this is the lady. So with this, I am concluding my ethical talk. Any questions from the participant will be appreciated.
Any questions, please?
A very good evening, good morning to everyone. I am Dr. Amit Tyagi from Lucknow. I am running my own center there. So to start up with, what ethical issues might be there, or how to, in a very small setups of 50 bed hospitals, can we come up with small trials of ECMO and everything, because we are having a good ICU setup. So is it like moderately acceptable to, or is it compliant to only big hospitals and corporate hospitals and government hospitals to run an ECMO center?
Well, sir, Venkat sir, please.
Yes. See, in small center ECMOs, we have two types of policy. One is an optimum ECMO and one is a resource limited ECMO. So where we have find an ECMO is essential and fund is a limitation, we go for reuse, we go for limited investigation, and many a times during COVID we have got at least more than 10 patients who are burnt out of resources. We charge them nothing for the hospital, and we say you just pay for the medicine. Then also we could manage their ECMO. So small center ECMO, the decision is fast, and the decision the outcome, whether they want to continue ECMO or they would afford or not, this things are faster. So therefore, I feel small center ECMO, you require a godfather to continue ECMO, because such situations keep on coming. And with your policy of trying to finally meet both the ends, is very important, and that you will have some compromise, but ultimately you could deliver justice. So small center is, ECMO is a better option than a corporate hospital, because you cannot do anything in corporate hospital on your own, whereas you can take many decisions in small center within a split second matter only.
Can I add, Arpan?
Yes, please.
Yeah. So first thing I'll say that it's the passion of ECMO physician. Whether the center is small or center is big doesn't matter. You should have one person should be mad for ECMO, and you should have a good team to help you for ECMO. This is one component, very important component. Probably I'll say most important. Then the logistics, as Venkat sir has said rightly, that your logistics, so you should develop your own protocols. You should be well trained, not that just you are doing ECMO for sake of doing ECMO, but you should be well trained. You must understand ECMO very well, and you can tailor your ECMO protocols as per your resource limited situation. And you must ensure whatever you do not have, you can arrange a backup for that. And but on the same side, you make sure that you are not compromising the quality of it. Because clinical judgment probably is the best. I give you, as Arpan was showing, that 81 days ECMO without changing the oxygenator. These are the strategies actually we should follow. That our anticoagulation protocol are very strict. Rather than just doing a factor 10A or doing a PTTK every 4 hours, they probably doing a ACT 4 times a day, but you are doing a torch test. You are ensuring that your ECMO flow is adequate or flow is unobstructed. So you are not interrupting circuit anywhere. Using a highly evidence-based infection control practices, so your antibiotic usage will be reduced. So you can run ECMO. The only thing, you have to be well versed with the ECMO. You should be very stringent about the protocol, and your clinical judgment and clinical assessment should be very good, so you can reduce the cost as well during your ECMO run. Definitely small centers should do, because if you are transporting a patient, you are adding a cost at least, and we are not sure that when you are transporting a patient, whether the patient will reach to the ECMO center or not. So ECMO, small ECMO center should do ECMO with a strict stringent protocols with ensuring the quality.
Sir, good morning. This is Dr. Rohit Bhomik. I am a pediatric intensivist. It's one of the new aims of West Bengal. So we are starting the program, and initially only 2 machines will be provided, and we are getting 2 machines. So the regarding dilemma of taking cases like the poisoning, like in that part of the country, we are getting to poisoning patient as well as simultaneously poisoning as well as suicidal attempts with drugs. So getting a patient with suicidal attempt and simultaneously a patient with viral myocarditis, to take between these two, sir, how to follow the ethical, these 4 columns? A patient, adolescent who want to end his life, and a pure viral myocarditis who per se wants to live a life, and his family also wants to live a life. To choose between a suicidal attempt patient and a patient on illness. We are getting these dilemmas in a new aims with minimum resources.
Aims cannot say it's minimum resources.
Sir, new aims, sir, new aims. It is not Delhi aims.
It's a new aims. So you have 2 machines now. Take both of them. Why are you segregating those things? So lights things apart. Things you have to take all of them. Because, you know, a adolescent who is taking some drug overdose, maybe momentary or a part of depression, whatever, that can be taken care later on. But suicide, you know, as you know better, you are a pediatrician, between 12 to 18 years of age, suicide has surpassed the, as a cause of death of everybody, from diarrhea, from heart attack, from everything, and it had topped the list in that category, 12 to 18. So we, if you ask Dr. Vivek Gupta, his life is full of suicides. So these are the cases. So, but you have to make them chance to get out of those. And poisoning cases, on the contrary, probably the outcome is better if they come in time. The worst part is the bad ARDS. You don't know what will happen. The lung will fibrose or something. The secondary infection will happen. All these things. But poisoning will give you a short, a good soothing outcome, and the morals of the team can be uplifted at that point of time. So don't think that poisoning you should not take from the moral ground and all this. And as well as the viral myocarditis, I think it's a good kind of cases. If you tell 10 indications, probably these two will top of the list with a very good percentage of outcome. Over to Vivek, sir.
Yes, absolutely right. I will use both machines because I have a hand crank with both the machine, and definitely I'll have a backup of roller pump. So, and both have a good outcome. If you say poisoning, your outcome can be as good as 70 to 80% survival if you have applied ECMO at right time and you are monitoring your patient well. Similarly, for viral myocarditis, again the outcome is good. You have to have a patience, because we have recently done a patient of a viral myocarditis, young doctor, postgraduate in the medicine. He had just a 5% of VF, and was on IABP ventilator with the highest possible inotropes, with the lactate in the range of 15 or above. And we had to do ECMO retrieval. Actually, we went and did ECMO and brought to our center. And we started with the 5, and on day 13, he was on normal LV functions, and we were able to remove ECMO on day 11. So after that, he's having absolutely normal cardiac function. So both these are young lives. There is a good chance of recovery. So both should be supported with ECMO. You should make your plan that you have a hand crank. Every staff should be trained how to do a hand cranking. That should be available, not that just hand crank is on the bedside. It has to be in a position that you can quickly switch over from your machine to doing a hand crank. And I'm sure today you will be, must have been trained, and today you will have exam for this also, to how to switch over to this. And definitely you have a backup of roller pump. So why to wait, keeping one machine standby? You must use both the cases. And the second issue is, please treat the patient, not his psychological status, that because he is a labile, he can have a second suicidal attempt, so we should avoid this treating this patient. No. As a protocol, what we do, any patient who had a suicidal attempt, we start following up the psychiatric and psychologist counseling since we start ECMO in patient. Once they are off ventilator, we develop a counseling session. And in fact, we are exceeding our counseling session in the post-discharge follow-up also, so that the reattempt or any other things can be addressed and patient can have his own normal life.
Hello. Sir,
Yes.
I'm Dr. Shiva Prasad. Sir, regarding the last case, the drowning case, by the time when you put that ECPR, you had understood that neurological status is not not recover, or maybe in a question. So you told you have removed the patient from ECMO after 40 days. But by the 10th day, or maybe 1 week or even 2-3 days, you might have understood that the neurological status is not going to come up. So what was is there a point to continue till 40 days? Because the family expense is increasing. Maybe they'll be completely devastated when they support a patient like this for quite a long time with a lot of money spent. They may be selling their properties and maybe trying to spend on the treatment. So is there a point in continuing the treatment for 40 days instead of making a decision by around 10 days where the patient's neurological status is not going to improve, if you are sure? Is there a point? How do you manage, how do you ethically deal with that? Because should we discontinue early, or should we continue till any results come?
No, actually, this patient, ECMO didn't continue for 49 days. The ECMO only continued for initial 2 weeks. He came out of ECMO, and he was not brain dead. You have to understand that he was not brain dead, and on ECMO you cannot go for MRI and all these things. After he got stabilized, came out, then we did MRI, showed a massive hypoxic brain injury. So, and he could not survive that. We continued for another 1 month after taking out of ECMO, and day 49 he collapsed because of the various these things, mostly because of the non-improvement from the hypoxic brain injury. One thing you have to understand, that patient who is not brain dead, you cannot discontinue the treatment. So, and sometimes there are fair chances of patients coming out. We have seen that brain is a difficult organ to predict. Sometimes they come out, sometimes and he was a young adult. So we continued thinking that might be some kind of things till the MRI happened. But MRI showed is a very bad injury, and we prognosticated the relatives, but they were not ready to accept that this has happened. So they asked us to continue things, and if any kind of improvement happens. So it was not a moral distress for the family, but it was probably the continuation of treatment for that. And I sincerely think that this no flow time is the most important predictor of your ECPR situation. But if you coming to a practical scenario, it is not easy to for this no flow, particularly in drowning, in this kind of cases. And there are some centers whose the ECPR protocol has been your inclusion criteria have shown NIRS lesser than 40. They are not taking as a case of ECPR. So I don't know how much it is applicable to us, and I will try to, because we are using NIRS in VA ECMO patients, but I don't know how much applicable to this kind of things. And at that point of time, when you are doing CPR and NIRS is showing, like the patient, some inclusion criteria shows that if your ETCO2 is less than 10, you should not attempt ECPR. That is also, we have seen that there is no ETCO2 in this kind of patients. So probably some deviations are accepted, but probably in drowning, hypothermia, in this kind of cases, whenever you get an arrested patient, you should, electrocution, whenever you are getting this kind of patient, you should give the chance to revive them. So if there is no question, we can conclude the session, because ethics is it can go long and long and long, and we can discuss it.
Arpan, can I say one more line?
Please, sir, please.
Whenever you are doing ECMO, there can be situation for ECMO nowhere for a particular organ, but it is possible that other organs are working well, and you must counsel the family for the organ donation in this situation if we are planning to withdraw the support on case-to-case basis. Yes, but as an ECMO physician, we must keep in mind, so that at least we can start increasing our organ pool.
I'll add another case with that thing, organ donation, in the next workshop, with the organ donation, ECMO assisted organ donation. Dr. Dipanjan has done it, so we will add this case after taking consent from him, how we promoted organ donation on ECMO. So if there is no questions, we can conclude, and next session will come.
Thank you, Dr. Arpan. Thank you, everybody.
Thanks to all panelists.